Welcome to the Health Exam CPC Practice Questions. Test yourself with 10 CPC exam-style questions and detailed explanations. For the full question set, visit cpc.thehealthexamsportal.com. Let's begin. When is an ABN form typically required? Your options are A, when providing any diagnostic test, B, when Medicare may deny payment for a service, C, for every procedure performed in an inpatient setting, D, only when services exceed a certain dollar amount. The answer is B, when Medicare may deny payment for a service. An advance beneficiary notice, or ABN, is used when a provider expects that Medicare may not cover a specific service. The purpose of the ABN is to inform the Medicare beneficiary before the service is provided that they may become responsible for payment if Medicare denies coverage. This protects both the provider and the patient by making sure the patient understands the possible financial responsibility ahead of time. Now let's look at why the other options are incorrect. Option A is incorrect because an ABN is not required for every diagnostic test. The key factor is not the type of service, but whether Medicare is expected to deny coverage. Option C is incorrect because ABNs are not required for every inpatient procedure. The requirement depends on Medicare coverage expectations, not simply where the service is performed. Option D is incorrect because there is no specific dollar amount that determines when an ABN is needed. The focus is whether Medicare may not cover the service. The key takeaway for this question is ABN means the patient is notified before a service that Medicare may not cover. When you see ABN on the CPC exam, think possible Medicare denial, patient notification, and possible financial responsibility. Let's move on to the next question. Question 2, which is true regarding ICD-10-CM codes. Your options are A, they are used exclusively for outpatient procedures, B, they replace CPT in both outpatient and inpatient settings, C, they are used primarily for coding inpatient procedures, D, they are interchangeable with HCPCS codes. Correct answer is C. They are used primarily for coding inpatient procedures. ICD-10-CM is designed specifically for inpatient hospital procedural coding. It is used to report procedures performed during inpatient hospital stays using detailed codes that describe the exact procedure performed. To accurately select an ICD-10-CM code, coders rely on detailed procedural information found in the operative report. This includes details about the procedure performed, the body system involved, the approach used, and other important characteristics required for proper code selection. Now let's look at why the other options are incorrect. Option A is incorrect because ICD-10-CM is not used exclusively for outpatient procedures. In fact, ICD-10-CM is primarily designed for inpatient hospital procedures. Outpatient procedures are generally reported using other code sets such as CPT. Option B is incorrect because ICD-10-CM does not replace CPT in both outpatient and inpatient settings. CPT codes are commonly used for outpatient services and professional procedures, while ICD-10-CM is specifically used for inpatient hospital procedure coding. Option D is incorrect because ICD-10-CM codes are not interchangeable with HCPCS codes. Each code set has a different purpose. ICD-10-CM focuses on inpatient hospital procedures, while HCPCS is used for reporting other healthcare services, supplies, and procedures. The key takeaway for this question is when you see ICD-10-CM, think inpatient hospital procedure coding. Remember this simple distinction: ICD-10-CM is used primarily for inpatient procedures. CPT and HCPCS are commonly used for outpatient services and other healthcare reporting needs. Knowing which code set applies to each situation is an important skill for the CPC exam. Let's move on to the next question. Question 3, what is the primary factor in DRG assignment? Your options are A, physician specialty, B, patient's preferred insurance, C, principal diagnosis and any applicable complications or comorbidities, D, duration of hospital stay. The answer is C, principal diagnosis and any applicable complications or comorbidities. DRG assignment is primarily driven by the principal diagnosis along with any secondary diagnoses that qualify as complications or comorbidities. The diagnosis information documented in the patient's medical record determines the appropriate DRG classification. Accurate and complete documentation is essential because the conditions documented can affect the assigned DRG and the reimbursement associated with the hospital stay. Coders must carefully review the documentation to identify all reportable conditions that impact DRG assignment. Now let's look at why the other options are incorrect. Option A is incorrect because physician specialty is not the primary factor used to assign a DRG. DRG assignment is based on the patient's diagnoses and documented conditions, not the specialty of the physician providing care. Option B is incorrect because the patient's preferred insurance does not determine the assigned DRG. DRGs are based on clinical information, diagnoses, and documented patient conditions, not insurance preferences. Option D is incorrect because the duration of the hospital stay alone does not determine the DRG assignment. While length of stay may be reviewed for hospital management and reimbursement purposes, the DRG is primarily determined by the patient's diagnoses and qualifying complications or comorbidities. The key takeaway for this question is, when assigning a DRG, always focus on the principal diagnosis and any documented complications or comorbidities. Remember, accurate documentation drives accurate coding and proper DRG assignment. For the CPC exam, when you see DRG assignment questions, think diagnosis first, then qualifying secondary conditions. abuse. Let's move on to the next question. Question 4. Which example represents fraud rather than abuse? Your options are A. Consistently undercoding services due to confusion. B. Mistakenly billing a service with the incorrect CPT code. C. Knowingly billing for services not actually performed. D. Routinely failing to collect coinsurance. The answer is C. Knowingly billing for services not actually performed. Fraud involves intentional deception or misrepresentation for personal or financial gain. In this example, knowingly billing for services that were never performed is considered fraud because the provider is intentionally submitting false information. The key word in this question is knowingly. When a person intentionally creates an inaccurate claim or misrepresents services provided, it moves from a mistake or improper practice into fraud. Understanding the difference between fraud and abuse is important because fraud involves intent, while abuse generally involves improper practices without the same level of intentional deception. Now let's look at why the other options are incorrect. Option A is incorrect because consistently undercoding services due to confusion does not demonstrate intentional deception. While it may result in inaccurate billing, the situation does not show that the provider knowingly attempted to misrepresent services. Option B is incorrect because mistakenly billing with the incorrect CPT code is generally an error, not fraud. Fraud requires intentional deception. A coding mistake without intent is handled differently from knowingly submitting false information. Option D is incorrect because routinely failing to collect coinsurance does not necessarily represent fraud. Although it may violate billing rules or create compliance concerns, this example does not show the intentional misrepresentation required for fraud. The key takeaway for this question is fraud involves intentional deception. When you see examples like knowingly billing for services that were never performed, think fraud because the action is deliberate. Abuse, on the other hand, usually involves improper billing practices, mistakes, or careless actions without the same intent to deceive. For the CPC exam, always look for the intent behind the action. Let's move on to the next question. Question 5. Which statement is correct about HCC coding in 2025? Your options are A. Only inpatient claims are affected by HCC scoring. B. Using unspecified diagnosis codes increases HCC scores. C. Accurate diagnosis coding can impact future payment models under risk adjustment. D. HCC coding applies exclusively to pediatric patients. The answer is C. Accurate diagnosis coding can impact future payment models under risk adjustment. HCC coding, or hierarchical condition category coding, assigns risk adjustment factors based on documented and reported chronic conditions. Accurate and specific diagnosis coding is important because it helps create appropriate risk scores, which can influence future payer reimbursement models and healthcare management decisions. When chronic conditions are properly documented and coded, the patient's overall health risk can be accurately represented. Now let's look at why the other options are incorrect. Option A is incorrect because HCC coding is not limited only to inpatient claims. HCC coding is used in risk adjustment models that evaluate documented health conditions across applicable healthcare settings. Option B is incorrect because using unspecified diagnosis codes does not increase HCC scores. Accurate and specific diagnosis coding is essential because it provides the detail needed to properly capture qualifying conditions for risk adjustment. Option D is incorrect because HCC coding does not apply exclusively to pediatric patients. HCC models are used to evaluate documented health conditions and risk across appropriate patient populations. The key takeaway for this question is, accurate diagnosis coding plays an important role in HCC risk adjustment. For HCC questions on the CPC exam, remember that specific and complete documentation of chronic conditions helps ensure accurate risk scores and appropriate healthcare payment models. Always focus on the importance of documentation and code specificity. Let's move on to the next question. Question 6, which is a recommended element of an OIG compliance plan? Your options are A. Automatically writing off all patient copays. B. Detailed training and education for staff on coding and billing. C. Only performing internal audits once every 5 years. D. Excluding the compliance officer from management discussions. The answer is B. Detailed training and education for staff on coding and billing. The Office of Inspector General, or OIG, recommends effective compliance programs that include staff education and training on coding, billing, and regulatory requirements. Regular training helps ensure that employees understand proper coding practices, billing procedures, and compliance expectations. A strong compliance plan also includes internal audits, corrective actions when issues are identified, and open communication throughout the organization. These elements help prevent fraud and abuse while maintaining accurate and compliant healthcare operations. Now let's look at why the other options are incorrect. Option A is incorrect because automatically writing off all patient copays can violate billing and reimbursement rules. Compliance programs focus on following proper billing practices, not avoiding required patient financial responsibilities. Option C is incorrect because effective compliance programs require regular monitoring and internal audits. Waiting 5 years between audits would not allow an organization to identify and correct potential compliance issues in a timely manner. Option D is incorrect because excluding the compliance officer from management discussions prevents effective oversight. Compliance officers need appropriate communication with leadership to identify risks, address concerns, and support compliance efforts. The key takeaway for this question is an effective OIG compliance plan depends on education, monitoring, communication, and corrective action. For CPC exam questions about compliance programs, remember that proper training and regular review help organizations prevent fraud, abuse, and billing errors. Let's move on to the next question. Question 7. Which statement is correct regarding HCPCS Level 2 codes? Your options are A. They are used exclusively for surgical procedures. B. They represent products, supplies, and services not included in CPT. C. They are only reported for inpatient hospital billing. D. They are assigned only by Medicare Part A. The answer is B. They represent products, supplies, and services not included in CPT. HCPCS Level 2 codes are used to report products, supplies, and certain services that are not represented by CPT codes. While CPT codes are commonly used for physician services and procedures, HCPCS Level 2 codes provide additional reporting for items such as durable medical equipment, medical supplies, certain drugs, and other healthcare services. These codes help ensure complete and accurate billing when a service or item is not captured by CPT. Depending on payer requirements, HCPCS Level 2 codes may be used in both inpatient and outpatient settings. Now let's look at why the other options are incorrect. Option A is incorrect because HCPCS Level 2 codes are not used exclusively for surgical procedures. They are primarily used for reporting supplies, equipment, drugs, and services that are not included in CPT. Option C is incorrect because HCPCS Level 2 codes are not only reported for inpatient hospital billing. These codes may be used in different healthcare settings, including outpatient services, depending on payer requirements. Option D is incorrect because HCPCS Level 2 codes are not assigned only by Medicare Part A. These codes are used by various payers and healthcare providers to report specific products, supplies, and services. The key takeaway for this question is think of HCPCS Level 2 codes as the code set that fills the gaps left by CPT. When you see items like medical supplies, durable medical equipment, or certain drugs, think HCPCS Level 2. For the CPC exam, remember that CPT reports many procedures and services, while HCPCS Level 2 captures additional products and services needed for complete healthcare billing. Let's move on to the next question. Question 8. Which statement correctly describes coding for SDOH in 2025? Your options are A. SDOH codes are optional and have no impact on reimbursement. B. Only a physician's documentation can be used for SDOH codes. C. SDOH codes can enhance risk adjustment and must be supported by documentation. D. SDOH codes replace all other ICD-10-CM diagnostic codes. The answer is C. SDOH codes can enhance the risk adjustment and must be supported by documentation. Social determinants of health, or SDOH codes, are used to capture important information about a patient's socioeconomic and psychosocial conditions that may affect their health and care. These codes, commonly reported using ICD-10-CM Z codes, provide additional information about factors that may influence healthcare needs, risk adjustment, and care management decisions. However, SDOH codes must be supported by proper documentation. Accurate documentation helps ensure that these conditions are appropriately captured and reported. Now let's look at why the other options are incorrect. Option A is incorrect because SDOH codes are not simply optional information with no impact. These codes can provide valuable information for risk adjustment and care management by identifying social and environmental factors that affect a patient's health. Option B is incorrect because SDOH codes are not limited only to a physician's documentation. Depending on applicable guidelines and payer requirements, documentation from qualified healthcare staff may also support reporting of certain SDOH conditions. Option D is incorrect because SDOH codes do not replace other ICD-10-CM diagnostic codes. Instead, they provide additional information about social and environmental factors that may influence a patient's health status and care needs. The key takeaway for this question is SDOH codes help tell the complete story of a patient's health by capturing important social and environmental factors. For CPC exam questions, remember that SDOH codes do not replace diagnosis codes. They provide additional information that can support risk adjustment and better care management when properly documented. Let's move on to the next question. Question 9. Which statement correctly describes upcoding and unbundling? Your options are A. Both are forms of appropriate coding practices. B. Upcoding refers to using a lower-level code than documented, and unbundling group services together. C. Both are considered improper billing practices that can lead to legal penalties. D. Upcoding is only an issue when billing inpatient procedures. The answer is C. Both are considered improper billing practices that can lead to legal penalties. Upcoding and unbundling are both considered improper billing practices that can result in compliance issues, financial penalties, and legal consequences. Upcoding occurs when a provider reports a higher-level service code than what is supported by the documentation, for example, assigning a code for a more complex service when the medical record does not support that level of care. Unbundling occurs when services that should be reported together as one combined service are separated into multiple codes in order to increase reimbursement. Both practices can create inaccurate claims and are serious compliance concerns in healthcare billing. Now let's look at why the other options are incorrect. Option A is incorrect because upcoding and unbundling are not appropriate coding practices. Both involve inaccurate reporting or manipulation of codes that can lead to incorrect reimbursement. Option B is incorrect because it reverses the meaning of upcoding and incorrectly describes unbundling. Upcoding does not involve using a lower-level code. It involves assigning a higher-level code than the documentation supports. Unbundling does not group services together. It separates services that should be combined. Option D is incorrect because upcoding is not limited only to inpatient procedures. Upcoding can occur in different healthcare billing settings whenever the reported code does not accurately match the documentation. The key takeaway for this question is always make sure the code matches the documentation. Upcoding means reporting a higher level service than supported. Unbundling means separating services that should be reported together. For the CPC exam, remember that both are compliance violations because they create inaccurate billing and may result in legal penalties. Now let's move on to the last question. For CCM services billed to Medicare, which criterion must be met? Your options are A. Patient must have a single chronic condition. B. Only a face-to-face visit is required each month. C. Patient must have 2 or more chronic conditions. D. CCM billing is limited to specialists. The answer is C. Patient must have 2 or more chronic conditions. Chronic care management, or CCM, is a Medicare service designed for patients with multiple chronic conditions that require ongoing care coordination. To qualify for CCM services, the patient must have 2 or more chronic conditions that are expected to last at least 12 months or until death, and that place the patient at significant risk. CCM also requires a comprehensive care plan and proper documentation of the services provided. The goal of CCM is to improve coordination of care and help manage complex patient needs. Now let's look at why the other options are incorrect. Option A is incorrect because CCM services require the patient to have 2 or more chronic conditions. A single chronic condition does not meet the basic eligibility requirement for CCM billing. Option B is incorrect because CCM is not based only on having a face-to-face visit each month. CCM involves ongoing care coordination, a comprehensive care plan, and meeting the required documentation and service requirements. Option D is incorrect because CCM services are not limited only to specialists. Eligible healthcare providers who meet Medicare requirements may provide and bill for CCM services. The key takeaway for this question is, for chronic care management, remember the number 2. The patient must have 2 or more chronic conditions expected to last at least 12 months or until death. For the CPC exam, focus on the eligibility requirements, documentation, and care coordination elements that support CCM billing. Want more CPC practice questions? Visit cpc.thehealthexamsportal.com.